All right, I guess I'll go ahead and get started. I'm Katie Lemming. I'm a PGY1 pharmacy resident here at UVA. And today I'm going to be talking about alpha-2 agonists and how they fit into the management of sedation in the pediatric patient. I do not have any disclosures or financial relationships with any commercial interests to disclose for this presentation. And this presentation will also include the discussion of off-label use of medications in pediatrics. So the objectives of this presentation, so at the conclusion of this presentation, participants should be able to distinguish between pharmacokinetic and pharmacodynamic properties of clonidine and dexmedetomidine, compare and contrast the use of dexmedetomidine with currently available therapies for procedural sedation in the pediatric patient, select an appropriate dosing and monitoring regimen for dexmedetomidine in a pediatric patient admitted to the PICU, and evaluate the appropriateness of clonidine for dexmedetomidine withdrawal. So we'll go ahead and get started. So I'll first be talking about the pharmacodynamics and pharmacokinetics. So is there variability between pediatric and adult patients? So first, a little bit of background. So agents, so the alpha-2 agonists we have are clonidine, which is your prototypical alpha-2 agonist. It's available in oral and transdermal forms as well as an intravenous solution that is not used for IV. You also have dexmedetomidine or Precedex, and this is a highly selective alpha-2 agonist available in an intravenous formulation. So the pharmacodynamic effects, so both of these are alpha-2 agonists. They work at the alpha-2 receptor, which is located presynaptically. So there's three subtypes. You have the alpha-2B subtype, which is located on vascular smooth muscle, and you also have the alpha-2A and 2C, which is mainly found in the nervous system. So the way that this receptor works is all three subtypes have been shown to inhibit adenylyl cyclase, which reduces the levels of cyclic AMP. And this leads to hyperpolarization of those noradrenergic neurons in the brain. And cyclic AMP reduction leads to potassium efflux through the calcium-activated channels, which prevents calcium ions from entering the nerve terminal. And this leads to suppression of neural firing. So this leads to inhibition of norepinephrine release and reduces activity in that pathway. So as I said, agonism of this leads to inhibition of neurotransmitter release and provides negative feedback. So it results in sedation, analgesia, and sympatholytic effects. So one thing I want to point out is receptor affinity. So there is a difference between dexmedetomidine and clonidine. So for dexmedetomidine, it has a receptor affinity of 1600 to 1 for alpha-2 over alpha-1. With clonidine, it's only 200 to 1. So as you can see, dexmedetomidine has a higher affinity for the alpha-2 receptor. So looking at dosing for dexmedetomidine, so I have the adult dosing listed for you on the left-hand side of the screen, and I want to contrast it to what is currently done in pediatrics. So for ICU sedation, there's usually no loading infusion that is given to the pediatric population, and this is due to the increased risk of side effects. And for the maintenance infusion, it's very similar to the adult population at 0.2 to 0.7 mics per kilo per hour, and this is adjusted based on the desired level of sedation. So in pediatric patients, there have been recorded doses of as high as 1 mic per kilo per hour. In pediatric studies, infusions as large as 2.5 have also been used, but this is thought that the larger doses, larger than 1.5, may not contribute to additional efficacy. I also have the dosing for clonidine listed here for you. Disclosure, this is not all-inclusive dosing. There are other dosings available. However, I wanted to provide an example to compare and contrast the adult dosing versus pediatrics. So I've provided the adult dosing for hypertension listed up there, contrasting it with the pediatric dosing, which is 5 to 10 mics per kilo per day divided every 8 hours with a max of 0.9 milligrams per day. So going into the adverse effects, so when we give an alpha-2 agonist, things that we can expect to happen are cardiovascular effects, so both hypotension and bradycardia have been seen, and the central nervous system, so you can have some agitation that occurs. So withdrawal syndrome, you want to avoid abrupt discontinuation in patients who have received greater than 24 hours of therapy. So if this happens, you can have rebound hypertension and rebound tachycardia. So I will mention the 24 hours comes specifically from the manufacturer, Per literature, it's generally seen in patients who have received greater than 3 days of therapy, and of course it is dose dependent. So going into the adult population and the pharmacokinetic and dynamic effects, so I have absorption. So as you can see, the onset of action for dexmedetomidine is 5 to 10 minutes, with a peak effect occurring between 15 and 30 minutes. And the total duration of action is about 60 to 120 minutes. For distribution, you can see that the distribution half-life is very rapid and occurs within 6 minutes. Protein binding is 94%, and metabolism occurs via hepatic mechanisms. And the elimination half-life, or terminal half-life, is approximately 2 hours. So I'm now going to compare this to the pediatric population. So there have been quite a few studies looking at dexmedetomidine and the pharmacokinetic effects. So the first 2 studies I'm going to point out are Petros et al., which looked at 36 children, completed the study, and they were aged 2 to 12 years of age. And this was in patients prior to induction of anesthesia. And these patients received a single 10-minute infusion, and they received a variety. There were several different groups, so there are 3 groups. They either received 2, 4, or 6 mics per kilo per hour. And during this study, they found that the protein binding was 92.6%, which is very similar to the adult population. And as you can see, I'll point out the clearance rate was 0.7 liters per kilo per hour, and the terminal half-life was 1.8 hours in this population. The next study by Diaz et al. Looked at kind of a slightly different patient population in that it was younger, and it included 10 patients completed the study with a median age of 2.6 years, with a range I have listed up there for you. And it was a post-surgical population, mainly cardiovascular surgery. And these patients received an IV loading dose of 1 mic per kilo per hour, followed by an IV infusion of 0.2 to 0.7 mics per kilo per hour. And in this patient population, the clearance rate was kind of similar to what was found in the other patient population in the other study, and then the terminal half-life was 2.6. So both of the authors of these studies concluded that these results were similar to those that were found in adults. So looking at further studies, so Vilo et al. Looked at kind of a further different population. So they looked at 2 different age ranges. They noticed that there wasn't really any information in dexmedetomidine in patients that were less than 2 years of age. So they kind of broke their group out into 8 children that were 28 days to 23 months of age, and 8 children that were 2 to 11 years of age. And these patients received 1 microgram per kilo over 5 minutes. And as you can notice, between the 2 groups, there was a statistically significant difference between the volume of distribution that was found, as well as the terminal half-life. So the half-life was longer in the younger patient population, so that patient population that was 28 days to 23 months of age. Potts et al. Looked at a very specific patient population. They were looking at patients that were post-cardiac surgery. These patients received a very similar dose of 1 mic per kilo over 10 minutes. And clearance rates in this study kind of, as you can see, were a little bit different at 0.56 liters per kilo per hour. And then I'll conclude with this final study that was most recently published. So this looked at both preterm and term neonates. And the term neonates is very similar to the same population that the Vio et al. Was looking at. And so as you can see, the age ranges I've listed up there for you, they received, they were broken up into several different groups. There was a level 1 group, level 2, and level 3, receiving different doses in each group. As you can see, the volume of distribution between the 2 groups was different at 2.7 liters per kilo and 3.9 liters per kilo. And then you can also see that the terminal half-life, which is one thing that I really want to point out, is also different at 7.6 hours for the preterm neonates compared with 3.2 for the term neonates. So kind of just a summary of what those studies showed. So several studies have evaluated the pharmacokinetic effects of dexmedetomidine in the pediatric population. And there's varying results, and this is likely due to the age of the patients that they were looking at. So studies that actually looked at the younger cohort of pediatric patients, specifically neonates, found significant differences when compared with older children. And authors in one study estimated that clearance rates in neonates were approximately 1/3 of adult values. However, they reached 87% of the adult values by 1 year of life. This brings us to our first assessment question. So, activation or agonism of alpha-2 adrenergic receptors leads to which of the following clinical effects? A, hypertension, B, respiratory depression, C, hypertension, or D, tachycardia. You are correct. I didn't hear it. So A is the correct answer. So respiratory depression isn't really seen with dexmedetomidine, and then hypertension and tachycardia can occur if you discontinue or abruptly discontinue or withdraw dexmedetomidine therapy. So the next patient population I'm going to be talking about is the use of dexmedetomidine in procedural sedation. So how does dexmedetomidine compare with currently available agents used for procedural sedation? So first I want to talk about why procedural sedation is necessary. So the goal of procedural sedation is to alleviate anxiety and pain and movement associated with imaging studies and invasive procedures. So you can see that it can be very scary for a child to undergo an MRI, and we definitely want to be able to get those imaging studies in order to properly diagnose them. So sedation agents definitely are a good tool that we use in order to obtain this. The currently available agents that we use are opioids, benzodiazepines, barbiturates, and ketamine, propofol, and etomidate. And so dexmedetomidine could potentially be a good option. So there's been quite a few studies that have looked at dex compared with these agents. So the first study I'll talk about looked at dexmedetomidine versus midazolam. And so they were looking at this in a specific patient population undergoing MRI examination. So I have listed the exclusion criteria up there. So they excluded patients with heart, lung, or neurological disease, a contraindication or allergy to any of the study drug, or if they've received the study drug within the last 30 days. This was a randomized prospective study, and patients were randomly assigned to receive either dexmedetomidine at a loading dose of 1 mic per kilo, followed by a maintenance infusion of 0.5 mics per kilo per hour, and midazolam at a loading dose of 0.2 milligrams per kilogram, followed by an IV infusion of 6 mics per kilo per minute. And doses were titrated per the protocol based on their sedation score. So the primary endpoints that they were looking at in this study was the quality of the MRI, the adequate sedation, and this was based on a Ramsey sedation scale. And what a score of 6 means that there's no response to a loud noise. Onset of sedation time, so the time from when the drug was started to achieving that sedation score, and then discharge time, so the time from when the drug infusion was discontinued to when the child was discharged from the unit. They also looked at several safety parameters, including mean arterial pressure, heart rate, peripheral oxygen saturation, and ventilatory frequency. And I have the statistical analysis listed up there for you. So results, so this study included 80 patients. Baseline characteristics were comparable between the two groups. So for the efficacy, as you can see, for quality of MRI, so they were given a score of 1, 2, or 3 for the quality of MRI. So 1 is no motion, 2 is minor movement, and 3 is major movement. So as you can see, for the score of 1 and 2, it was a statistically significant difference between the dexmedetomidine and the midazolam group. So the patients that received dexmedetomidine had a higher quality MRI in that they had no motion or they had minor movement. And then if you also look at inadequate sedation, you can see that 32 patients in the midazolam group had inadequate sedation compared with 8 in the dexmedetomidine group. And the next one is the onset of sedation. So there was a statistically significant difference between the onset of sedation in the patients that received midazolam compared with the dexmedetomidine group. For the safety parameters, MAP, heart rate, and ventilatory frequency decreased significantly from baseline in both groups when compared to themselves. But when looking at them compared from the dexmedetomidine to the midazolam group, there was not a statistically significant difference between the two groups. So what does this mean for dexmedetomidine when compared with midazolam? So it provided adequate sedation without affecting hemodynamics and respiration and may provide a useful agent in procedural sedation in the pediatric population. The next agent we'll look at is propofol. So this study was actually completed by the same authors that completed the midazolam study. So the study design was very similar in that it was a randomized prospective study looking at propofol. And I have the dosing listed up here for you for the dose of propofol that they received. So they looked at very similar primary outcomes. So they were looking at the quality of the MRI, adequate sedation, the onset of sedation time, and discharge time, as well as the same safety parameters that were looked at in the previous study. So the results of this study included 60 patients, and baseline characteristics were not statistically different between the two groups. So for the safety parameters, both MAP and heart rate decreased significantly from baseline in both groups, and that's when they were compared within their own population. And then for the group that received propofol, heart rate was significantly more rapid and the mean arterial pressure was lower at several time points. However, this was not clinically nor statistically significant. And the maximum decreases in respiratory rate were 8% and 17% in the groups that received dexmedetomidine and propofol respectively. So when looking at the efficacy, so as you can see, the quality of MRI was not statistically different between the group that received Dex and the group that received propofol. And then when looking at onset of sedation, so the patients that received propofol had a shorter time to onset of sedation, as well as a shorter time to discharge. So that means that propofol came on quickly as well as came off quickly in this patient population. All right. So summarizing kind of what the conclusions were of this study. So both propofol and dexmedetomidine provided adequate sedation. Although propofol provided more rapid rates of anesthetic induction and recovery, hypotension and desaturation were seen in these patients, although not statistically significant. And due to these adverse effects, dexmedetomidine could be an alternative sedative drug to propofol in these patients. And the final drug I'll look at is pentobarbital. So it is a drug that we use here at UVA. For sedation, for procedural sedation. So in this study, they were looking at induction time, recovery time, total sedation time, sedation failure rate, and adverse outcomes for patients that received either pentobarbital or dexmedetomidine. And this was a retrospective chart review, and I've listed the dosings the dosing that the patients received. So I do want to point out that it was IV pentobarbital that was received by these patients. And if needed, midazolam was administered as a 1 milligram dose until sufficient sedation was achieved with a max of 2 doses. So as I said, primary outcome was recovery time, and then the secondary outcomes were looking at the induction time, total sedation, adverse effects, and failure of sedation. So there were 266 patients included in this study with baseline characteristics that were not statistically different between the two groups. But when looking at failed sedation and induction time, there was not a statistically significant difference between the two patient populations. However, with recovery time and total sedation time, there was a statistically significant difference. So as you can see, the dexmedetomidine group had a total sedation time of 106 minutes compared with 141 with the pentobarbital group. So you can see that they had a shorter total sedation time with the dexmedetomidine. And then for recovery time, the patients that received dexmedetomidine had a shorter time to recovery compared with the pentobarbital group. And then I have the total doses listed for the pentobarbital and the dexmedetomidine listed for you there, as well as the percentages of patients that received that specific dosing for their procedure. And then also I've listed down on the bottom of the screen the midazolam dosing. So as you can see with the pentobarbital group, 45% of the patients had to receive additional doses of midazolam in order to achieve adequate sedation, whereas with the dexmedetomidine group, it was also 40%. So what does this mean for pentobarbital versus dexmedetomidine? So they were both associated with successful sedation prior to MRI. Dexmedetomidine had a shorter recovery and total sedation time. However, both agents can still be used for MRI sedation. It's just we now know, kind of based on these studies, that dexmedetomidine could be an appropriate agent to use in procedural sedation. So this brings us to our second assessment question. So dexmedetomidine, when compared with pentobarbital for pediatric MRI sedation, provided which of the following effects? A, dexmedetomidine had a longer time to induction of sedation. B, dexmedetomidine failed to provide adequate sedation. C, dexmedetomidine had a shorter time to recovery and total time of sedation. Or D, patients who received dexmedetomidine required more midazolam doses to achieve the goal sedation score? C, yes, that is the correct answer. So moving on to a different patient population. So we're going to be looking at dexmedetomidine use in the pediatric intensive care unit. So sedation in the PICU, current practice varies widely from institution to institution, and combination therapy is often required in these patients. So commonly used agents that we see a lot of the time are opioid analgesics and benzodiazepines. So while these agents have established efficacy in the PICU environment, they are not without their own side effects. So dexmedetomidine provides a really good option and has several advantages over current agents that are used in the PICU. So there's preservation of respiratory drive, they provide adequate levels of sedation, there's reduced duration of delirium and or coma, and shortened duration of mechanical ventilation. So now I'm going to look at a few studies that looked at dexmedetomidine specifically in the pediatric patient population. So the first study looked at dexmedetomidine in acute respiratory failure. So they wanted to describe the dexmedetomidine use in patients supported with mechanical ventilation for acute respiratory failure. So this was a secondary analysis of the randomized evaluation of sedation titration for respiratory failure, or the RESTORE trial. And this was a clustered randomized trial that compared usual care to a nurse-implemented goal-directed sedation algorithm in children with acute respiratory failure. So the reason why this is a secondary analysis is because dexmedetomidine was not evaluated as an objective during the parent study. And it included 31 PICUs participated and were randomized to receive either usual care or intervention over 4 years. And this article and study focused on kind of the group that received usual care, because the intervention group in the actual parent trial had restricted use of dexmedetomidine. So in this patient population, patients were divided into 4 groups. So either dexmedetomidine as a primary sedative, which was defined as dexmedetomidine initiated on the day of, or the day initiated within the first 2 days of intubation and administered for greater than or equal to 50% of the intubated days, and not used as a peri-extubation agent. For dexmedetomidine as a secondary agent, it was defined as dexmedetomidine used but not for peri-extubation or a primary agent. And then for peri-extubation, it was initiated on the day of or the day before extubation. So the primary endpoints that they were looking at were the sedatives administered, so opioids, benzodiazepines, as well as secondary sedatives, the number of different sedative classes received, and anti-delirium medications. And of note, neither trial, either the parent study or this study, specifically said what they defined as anti-delirium medications. Measure of wakefulness, pain, and agitation was also looked at, including the study days awake and calm, the days to first awake and calm state, and study days with an episode of pain or agitation. And they also looked at sedation-related adverse events, and I've listed the statistical analysis up there for you. So breaking this group out, so I'll first talk about dexmedetomidine as a primary agent. So a total of 596 patients were included in this study, and 138 received dexmedetomidine as a primary sedation agent. So this population included children with a lower median PRISM score, and this is the Pediatric Risk of Mortality score, and it's a frequently used physiologic-based severity of illness measure to estimate the mortality risk of this hospitalization. And it also included more children with asthma or reactive airway disease. So when looking at this patient population, the mean dexmedetomidine daily dose was 0.6 mics per kilo per hour, with a median duration of exposure of 6 days. In this patient population, they were exposed to significantly less opioids. However, they received more sedation classes, specifically propofol and ketamine, in order to achieve adequate sedation. These patients had more study days with an episode of agitation and had a shorter duration of mechanical ventilation. So moving on to the next group of patients. So this is dexmedetomidine as a secondary agent. So this patient population included 280 patients that had severe pediatric acute respiratory distress syndrome and children with a greater number of dysfunctions on admission. So in this patient population, the mean daily dose was very similar to those with the primary sedative agent of dexmedetomidine at 0.6 mics per kilo per hour, with a median duration of exposure of 4 days, so slightly less than as a primary agent. These patients were exposed to significantly more opioids and benzodiazepines and sedative classes when the dexmedetomidine group as a primary agent was excluded. So I found this to be very interesting that a lot of the analyses for the secondary groups excluded dexmedetomidine as a primary agent when doing their statistical analysis. They also had more anti-delirium medications that were started and had more study days with an episode of pain, inadequate pain management, and agitation. They also had a longer duration of mechanical ventilation and a longer length of ICU stay and length of hospital stay. So looking at the final group, so dexmedetomidine used as a peri-extubation agent. So this patient population included 178 patients, and it included fewer children with sepsis-related acute respiratory failure and more with asthma and reactive airway disease. So the mean daily dose of dexmedetomidine was 0.3 mics per kilo per hour, with a duration of exposure to be expected of 2 days, significantly less than the other groups, due to the definition that they used for peri-extubation. These patients were exposed to significantly more sedative classes than those who did not receive dexmedetomidine and had more study days with an episode of agitation or pain. So kind of the results of this study showed that dexmedetomidine as a primary sedative agent wasn't effective in patients with a low criticality, and adding dexmedetomidine on as a secondary sedative agent did not add any additional clinical benefit. So looking at dexmedetomidine versus midazolam, so this was another study that looked at dexmedetomidine for post-operative sedation. So it was comparing the quality of sedation between patients that received midazolam and fentanyl versus those that received dexmedetomidine and fentanyl. And this was in patients with congenital heart disease following cardiac surgery. So this was a retrospective study, and I've listed the inclusion criteria there for you. And then the treatments, so they either divided into two groups. So they either received dexmedetomidine and fentanyl, or they received midazolam and fentanyl. And I've listed the treatment doses up there for you. So the primary endpoint that they were looking at in the study was delirium scores, and that was using a PAED score, which is the Pediatric Anesthesia Emergence Delirium Score. And the way this is broken down is there's several different criteria, and the patients are scored based on how they respond. So one example is child makes eye contact with caregiver, child's actions are purposeful, child is aware of his or her surroundings. And behavior greater than or equal to a score of 10 is considered emergence delirium. They also were looking at length of mechanical ventilation as well as length of sedation treatment. So in this patient population, it included 187 patients. Baseline characteristics were similar between the two groups. So for the dexmedetomidine group, you can see that the length of sedation treatment was not statistically significantly different between the dex and the midazolam group. The length of mechanical ventilation was not statistically significantly different. However, when you go down to the doses of midazolam and the doses of morphine, you can see a statistically significant difference between the doses that were received in these patients. So of note, patients in the dexmedetomidine and fentanyl group were able to receive midazolam if additional sedation was needed and not achieved with the primary agents. And for their scale, you can see that based on the delirium scale, patients that received dexmedetomidine had a lower score on the scale compared with the midazolam group, and this was statistically significant. And the incidence of emergence delirium occurred more in the midazolam group compared with the dexmedetomidine group. So there was no difference in the duration of sedation treatment and mechanical ventilatory use between the two groups. However, patients administered the dexmedetomidine and fentanyl combination received a lower dosage of additional sedative analgesic drugs and had a lower incidence of delirium. So this brings us to our next assessment question. So AB is a 9-day-old, 2.75 kilo male with postnatally diagnosed transposition of the great arteries. Now postoperative day 1 from patent ductus arteriosus ligation, arterial switch, and primary closure. His vital signs are listed up there for you. He is currently on milrinone and epinephrine drips to maintain MAPS greater than 40, and he is intubated on morphine and midazolam, and the team would like to start dexmedetomidine for additional sedation. What starting dose of dexmedetomidine would you recommend? So A, start with a loading infusion of dexmedetomidine of 1 mic per kilo, followed by a maintenance infusion of 0.2 mics per kilo per hour. B, no loading infusion and start a maintenance infusion of dexmedetomidine 0.2 mics per kilo per hour. C, start with a loading infusion of dexmedetomidine at 0.5 mics per kilo, followed by a maintenance infusion of 0.6 mics per kilo per hour. Or D, no loading infusion, start a maintenance infusion of 0.2 milligrams per kilogram per hour. So B is the correct answer. So I would like to point out that this kind of goes against what I talked about in the first study that I mentioned, but here at UVA we actually do use dexmedetomidine as a third agent and do see benefit in the children that we have here at the hospital. And generally other studies that have looked at dexmedetomidine have also shown that it is an effective sedative agent. And of course, the reason why again, we don't start a loading infusion is because of the adverse side effects that occur of bradycardia and hypotension. So next, I'll be talking about discontinuation of therapy, so dexmedetomidine withdrawal. So withdrawal. So abrupt discontinuation of Dex could produce withdrawal symptoms similar to those seen with abrupt discontinuation of Clonidine. So it's most likely to be seen when greater than 24 hours of therapy have been received. However, I will point out this again is the manufacturer's recommendations. In literature, it's generally greater than 3 days of therapy is when we can see the withdrawal symptoms occurring. Possible symptoms that'll happen are agitation, irritability, headache, and rebound hypertension. So withdrawal symptoms have been reported in several case reports and retrospective case series in pediatric patients. So Weber et al. Is an example. So they described a 2-year-old patient, 15-kilo male, who immediately following discontinuation of dexmedetomidine at 0.4 mics per kilo per hour experienced those symptoms of withdrawal, so tachycardia, hypertension, and emesis. So in this patient, he had been receiving therapy for 6 days, and this was following a cardiac cath and a Fontan operation. So dexmedetomidine was restarted, and the symptoms of withdrawal decreased and went away with the reinitiation of the infusion. So after 24 hours in this patient, dexmedetomidine infusion was weaned off by 0.1 mics per kilo per hour every 8 hours without any further adverse effects. So this goes to show that in literature or in these case reports that dexmedetomidine withdrawal is a real possibility. So there was, and you might ask, is there a way to prevent this withdrawal from happening? So this study actually evaluated Clonidine for dexmedetomidine withdrawal. So it was evaluating it in pediatric patients who were weaned from long-term dexmedetomidine. I've listed the inclusion or the exclusion criteria for you. And so, for example, a patient with cyanotic heart disease, primary pulmonary hypertension, neuromuscular respiratory failure, or ventilatory dependent on PICU admission were excluded from this patient from this study. It was a retrospective single center study, and patients were divided into 2 groups. They were either weaned from dexmedetomidine only, or they received transdermal or enteral Clonidine while being weaned. So of note, the typical weaning for dexmedetomidine at this institution was decreasing by 0.2 to 0.5 mics per kilo per hour, with changes made every 12 hours, with the goal of reaching 0.2 to 0.5 mics per kilo per hour prior to discontinuation. However, the actual dose that it was decreased by was at the discretion of the attending physician. Also, the attending physician was the one who had made the decision to either start Clonidine or just stay with the dexmedetomidine withdrawal, and they also made the decision which formulation to use. And if the patch or the transdermal route was chosen, it was started 2 days prior to the initiation of the wean. So the primary endpoint was looking at the withdrawal score assessed by the Withdrawal Assessment Tool 1, or WAT1. So this looked at several different criteria. So it evaluates kind of symptoms in the previous 12 hours, as well as 2 minutes pre a stimulus observation, during this a 1 minute stimulus observation, and then post-stimulus recovery. And you're given a score based on these criteria, and that is how they determine what your WOT1 score is. They also looked at the incidence of rebound hypertension, which they defined as an increase in blood pressure by 20% or more compared with the pre-wean time period, an incidence of rebound tachycardia as well, which is defined as an increase in heart rate by 20% or more compared to the pre-wean time period. And I've listed the statistical analysis up here for you. So this patient population included 20 patients, and baseline characteristics were not statistically different between the two groups. Those that were in the Clonidine group actually all received the transdermal patch, and it was placed an average of 5.6 days prior to initiation of the dexmedetomidine withdrawal. The mean dose of Clonidine used was 9 micrograms per kilo per day. 12 patients were started on the 100 microgram per 24-hour dose, and then 1 patient was started on the 50 microgram patch, and they covered half of the patch with Tegaderm. And 2 patients had their Clonidine dose increased from 100 to 200 and 300 in one patient population. And those patients received an extended duration and larger doses of dexmedetomidine. So when looking at the Clonidine group versus the no Clonidine group, you can see the duration of dexmedetomidine in the Clonidine group was statistically significantly longer than those that received no Clonidine. And the cumulative dose that was received was also larger in the Clonidine group compared with the no Clonidine group. The mean dose that was received was not statistically significantly different between the two patient populations, as well as the maximum dose was not statistically significant. And as you can see, the WAT scores, and this is 24 hours post-wean, was not statistically significantly different. However, you can see with the Clonidine group, it was 0.8 average of a score, compared with the no Clonidine group had an average of 3.2. So you can see there is a difference, although not statistically significantly different. And then when looking at heart rate in these two patient populations, so there was a statistically significant difference in the change in pre and post-wean between the two groups, with the no Clonidine group having a statistically significantly higher heart rate compared with the Clonidine group. And one thing I forgot to mention is the rebound tachycardia. So patients that experienced rebound tachycardia between the two groups was not statistically significant. So in being weaned from long-term dexmedetomidine, those that received Clonidine trended towards fewer withdrawal symptoms than those who did not. And that was based on the withdrawal score, or the WOT1 score. So when looking at Clonidine for withdrawal, how do you dose it? So there's no specific dosing recommendations for Clonidine for dexmedetomidine withdrawal, but we use that hypertension dosing for pediatrics as kind of a guideline. So here at UVA, we use 5 to 10 mics per kilo per day divided every 8 hours. So Clonidine is also used for neonatal abstinence syndrome, and so that you can also use that dosing as kind of a guideline for dosing in dexmedetomidine withdrawal. And then when it comes to the transdermal patch, so it takes 2 to 3 days to achieve therapeutic levels. So generally in the beginning, the transdermal patch is not going to be the option that we choose first or right off the bat. We may stay with the oral first, and then if they need to be on Clonidine for a longer period of time and they're on a stable dose, we can then consider the transdermal patch. So this brings us to our final assessment question. So ZY is a 4-year-old, 10-kilo female with a history of severe asthma with multiple past hospitalizations. She was admitted to the PICU following intubation for severe asthma exacerbation. Flu and RSV tests were positive. She was started on morphine, midazolam, and dexmedetomidine. So on hospital day 10, the patient's clinical status begins to improve. They were successfully being weaned off of midazolam and morphine, and they're currently on dexmedetomidine 0.8 mics per kilo per hour. And the team would like to discontinue dexmedetomidine. Would like your advice before proceeding. What advice would you give the team when discontinuing dexmedetomidine? A, discontinue dex, no wean is necessary. B, wean dexmedetomidine by 0.2 mics per kilo per hour every 3 hours and monitor for symptoms of withdrawal. C, start Clonidine at 5 mics per kilo per day and begin to wean dexmedetomidine by 0.2 mics per kilo per hour every 12 hours. Or D, discontinue dexmedetomidine and start baclofen. So C is the correct answer. So we definitely do want to wean dexmedetomidine. We don't want to abruptly discontinue because you can have those symptoms of rebound hypertension and tachycardia. The reason why B is not the correct answer is because we don't really want to decrease the dose of dexmedetomidine by every 3 hours. We want to extend the period out to every 8 hours or every 12 hours, just because we want to prevent those symptoms of withdrawal from appearing. And then, of course, D is an incorrect answer as well. So in summary, clonidine and dexmedetomidine are alpha-2 agonists that have sedative, analgesic, and anxiolytic effects. So dexmedetomidine pharmacokinetic parameters are significantly different in neonates compared with older children. And as I said before, authors in one study estimated that clearance rates in neonates were approximately 1/3 of adults, but reached 87% of adults' values by 1 year of life. So dexmedetomidine, when compared with currently available agents for sedation, provided adequate sedation for procedural sedation while having limited effects on hemodynamics and respiratory drive. And then when looking at withdrawal from dexmedetomidine, it has been reported following abrupt discontinuation when greater than 24 hours of therapy have been received. Clonidine, when combined with a dexmedetomidine withdrawal, is an effective agent to reduce rebound tachycardia. And that concludes the presentation. What questions do you have for me?
So the study that you looked at for clonidine versus no clonidine with Precedex, did you have any comment at all about the duration of Precedex between the two groups?
So it seemed like when they started the group that received clonidine, they took longer time to wean off the dexmedetomidine compared with the no clonidine group. So I think that's why the duration as well as the duration and what was the other one? Sorry. The duration and the cumulative dose were both higher. Also, one thing that the authors mentioned is that the patients that ended up receiving clonidine and the reasons why the attending decided to use clonidine in these groups was because they had been on it for a longer period of time, so they were more concerned with the withdrawal symptoms occurring.
In the majority of all the information that you've presented, even for your procedural sedation, they added a second agent in. And then for your continuous sedation in the PICU, it was added into another agent. Would you ever recommend dexmedetomidine as a single agent?
So I personally don't think dexmedetomidine as a single agent it should be used, just because it does have some analgesic properties, but it doesn't have enough. And there's a lot of pain that can be associated with kind of just being in the PICU or whatever operations or procedures that they've had done or for the reason of hospitalization. So I feel like we need that additional agent on board to kind of help with the analgesic effects as well. I feel like dexmedetomidine provides adequate sedation, but the pain component is definitely where we would need a second agent on board. All right, that concludes the presentation. Thank you for coming.